Dr. Potee.
Sorry, just wanted to get that on there.
We have been trying to bring Dr. Potee to do a training for us ever since I heard her for the first time. You were doing a training in Hampden County. Sorry, it was Hampshire County. And that was several years ago. And I am still thinking about it. I'm still talking about it. I found it to be so powerful and thought-provoking. So I am just so thrilled to be able to, have you here to speak with our volunteers. And many of you on the call are not yet volunteers. For those of you who've listed, you're not a volunteer in the sign up. Please expect to hear from us. We'd love to talk to you about some of the important work we're doing relative to substance dependency and also in other areas to build resilience in both Franklin and Berkshire County. So I'm Corinne McEwen. I'm the director. I think I may have forgot to say that. And now I'll let Christy do the formal intro.
Fabulous thing. Yeah, thank you. So welcome to everyone that's joined us tonight. I am Christy Lemoyne. I'm the volunteer coordinator for Berkshire and Franklin MRC units. For those of you who are not familiar with the Medical Reserve Corps, or MRC as we call it, it was a group that was brought about following 9/11 when people wanted to go and help in their local communities for local emergencies. And it was created as a way to pre-credential and train local volunteers to respond in those kind of circumstances. So it is a network of over 800 individual units across the United States, although there are also units internationally as well. Altogether, we have over 300,000 volunteers at this point in time, and all of them are people in their local communities, like I said, just looking to get involved and help in whatever way they can. So our particular units have all kinds of programs going. We've done a lot with COVID testing and vaccinations. We've assisted with food access to vulnerable populations, some art resilience programs, oral histories, well-being checks, some collaboration with local health projects, and canine therapy. We have a slew of projects. So if there's anything that people are interested in, we always try and find a way to connect them to our communities. So on to what we're here for tonight, and that is to welcome Dr. Potee, our speaker tonight. She is a board certified family physician and addiction medicine physician who works in Western Massachusetts. She attended Wellesley College, Yale University School of Medicine, and did her residency at Boston University, where she remains an assistant professor of family medicine for over 8 years. She's currently the medical director for the Franklin County House of Corrections and director of addiction services for Behavioral Health Network, and the medical director for the Pioneer Valley Regional School District as well. She is also the co-chair for the Healthcare Solutions Committee of the Opioid Task Force in Franklin County and North Quabbin Region. She was named Franklin County Doctor of the Year by Mass Medical Society in 2015, and Dr. Potee engages communities in discussions surrounding substance abuse through her wide-ranging series of talks. So without further ado, Dr. Potee, take it away.
Thank you. Thanks, Christy. Thanks, Corinne. Thank you. Thanks for welcoming me so warmly. And I was supposed to do this talk right before COVID hit, is how I remember it. And then COVID hit, as we all remember, and nothing happened, except I signed up for MRC. As soon as COVID hit, I put my name in the bucket and I was like, I need to help out. The truth is I did a little vaccine stuff, but otherwise almost nothing. But I love your emails. I feel really grateful for the organizational work that you all do. I mean, I think we all watched it happen, 3 years ago of, wow, a lot of us who have any medical or organizational ability need to step up when there's a crisis, because that's not going to be our first pandemic that most of us are, not the only pandemic that most of us are going to see. We need to prepare for one that's going to happen in another 2 years as well. So I'm really grateful to the MRC for the work that you all do. I'm going to share my screen. I'm also going to ask people, if you don't mind, your name and sort of a little bit, what you do or what your connection is to this kind of work. I would love to see that because it helps me to understand who the audience is. And
put that in the chat, please.
In the chat. I'm sorry.
I did just send a message, so everyone should be able to find it if you're not familiar.
Perfect, thank you. And I think what we'll do, if it's okay with you all, Christy's going to monitor any questions in the chat that come up. And if it seems like it's something that is of time importance, she's going to interrupt me and then ask the question, because I can be interrupted easily. And I think that what I'll do is I'll deliver most of the talk because there's a flow to it, and then we can unshare the screen, and then we can just talk to each other and ask questions in our in real time at the end. So we're going to spend time talking about the human brain, which is the organ that's impacted with substance use. That obviously the skin, the heart, the kidneys sometimes can be involved, the liver, of course, with alcohol, but it's really the brain that is the pathway that develops. It's the organ that gets the most damaged when somebody develops substance use. And, I apologize to Corinne in the beginning. I said I've been doing this talk or a similar talk almost every week since 2013. And my talk has changed. I've gotten more knowledgeable. I've changed my slides. I've looked at some of my slides I used to use and thought, my goodness, I can't believe you thought that or said that, or it's not true, or the science has disproven this thing. So I try to keep it up to date. I am going to tell you a story that is a simple story because it's the easiest way to understand it. There's a point in this process where it goes well over my head, and I've been doing this work for a long time, but the story I'm going to tell is a way that you all could go walk into a high school or middle school and give this talk yourselves. The part of the brain that's injured when it comes to substance use is the reward circuit of the brain. And it's these three sections of the brain: the prefrontal cortex, the nucleus accumbens, and the ventral tegmental area. And it's the part of the brain that basically tells you to survive. Wake up every day, find food, water, enough calories to survive, and procreate, make more generations ahead of you. That is really, from an evolutionary standpoint, the point of us on this planet, right? It's not to go walk your dog or go for a hike or wash the dishes in the sink. It is to actually survive long enough that you can send generations forward. It's this part of the brain that is impacted with substance use. It's one of the reasons it's such a hard struggle to help people get better, because this is one of the most elemental parts of the brain. The neurotransmitter most at play with substances is dopamine. Now, there's several other neurotransmitters that have a role. Obviously, nicotinic receptors play a role, the cannabinoid receptors play a role, glutamate and GABA play a huge role, but at the end of the day, they touch dopamine. And dopamine is this neurotransmitter that is the holy smokes, that was awesome, do it again. And when you don't do it, I will make you feel terrible neurotransmitter. So it gives you a lot of motivation. It gives you this strong sense of reward or pleasure. It has with it associated fine motor skills. And you all have a grant that I just heard about doing work on helping people in recovery to help stick the landing, to feel better. And working with hands and fine motor skills and doing art or crocheting or building things is actually part of recovery for many people, because the fingers remember, the hands remember, right? The body keeps the score, and there's muscle memory. That motor functioning through dopamine is a real part of the story. The two behaviors associated with dopamine are compulsion and perseveration. I have to do this thing and I am unable to stop, right? I can only think about it. So those are some of what dopamine does to the brain. And you look at that and you're like, yeah, I get it. I take care of people who struggle with substance use. My brother has substance use. All of us have some relationship to it. It's very rare for you to meet somebody who has no relationship. And you see some of what I'm describing with the dopamine system. So some of us have baseline just high dopamine, right? There are happy people. We just, we're kind of blissed out. We're sort of the golden retrievers of the planet. When I ask a big room sometimes, who in here think they have high dopamine? It's a small number though. It's always less than 10% of the room. And I actually sit in this part of the world. I actually think I have slightly lower than average dopamine, and I do things every day that make me feel better. I exercise almost every day. I have strong connections to other people. We all do things that are healthy, that make us feel good. And if you were to put yourself into a functional MRI at the time you do it, you would see a little spike in dopamine. And I don't know what everybody on this call does, but you might want to ask yourself, when you're feeling down, when you're feeling out, what do you do that makes you feel good? And it can be any number of things. People will tell me they dance, they listen to music, they call a friend, they reach out and connect. dopamine has in treatment for substances has a very strong relationship to connections to other humans. And that's why things got much worse during COVID. So to talk about it from a substance standpoint, if the average person has in their brain 100 units of dopamine, now there is no way to measure this. This is not actually a serum blood test that is done, but this is for demonstration purposes. If most of us are sitting at 100 units of dopamine, and I already told you I sit at 95 units of dopamine, and there's at least 3 golden retrievers on this call who sit at 110 most of the time. If you have amazing food that just makes you feel great and you appreciate that, your dopamine spikes. It goes up and then it goes back to normal again. It goes to 150. If you have a great night, you have good consensual sex and great food, it might spike to 200 and then it goes back to normal. That's what your brain has learned to do over the last 200,000 years to survive and to continue on this planet. So spikes and lowering of dopamine is normal. It's supposed to be like that. Once you start getting exposed to certain chemicals, however, you start to get these spikes and crashes of dopamine that aren't actually consistent with like evolutionary health. So when you use cocaine, you might spike to 350. If you use a strong prescription opiate and you like prescription opiates, it might go to 500. Heroin or fentanyl might bring you to 900 or 1200. Methamphetamines are some of the most potent dopamine spikers we know, 1300 or higher. And people will say, yeah, the first time I used is the best thing I remember in my life. And in many people's case, that use is coming from a place of dysphoria or of trying to escape bad feelings. And so this is a dramatic change for them from their baseline. And the thing is, you never get those kinds of spikes again. And in fact, what happens is that the brain is downregulates in a way that I'm about to describe. So we're going to talk about 2 specific substances, both addictive for some people, and how it actually works. So there's 3 things in the brain that govern the amount of dopamine seen. One is how much dopamine is produced. 2, how many dopamine receptors are available on the other side of the synaptic cleft receiving the information. And the 3rd thing is how many little vacuums the dopamine reuptake transporters are sucking dopamine out of the synaptic cleft. How much is made, how much is absorbed, and how much gets sucked away. Those are the 3 things in the equation that affect dopamine. So cocaine is a really simple drug to understand because it really does one thing to the brain. It turns off the vacuum. It stops the dopamine reuptake transporter from returning the dopamine to the original nerve terminal. And so you get a nice big buildup of dopamine in the synaptic cleft. You would think, knowing how simple the mechanism of action is with cocaine, that this would be an easy thing to treat. And yet, most of you guys are medical people, it is actually not an easy thing to treat. When you actually struggle with a cocaine use disorder and you really can't stop, I don't have any magic pill to give you to help you stop. There's some therapeutic methods that have some evidence behind them, including contingency management, where you reward people for not using, and that works quite well for the stimulant disorders, methamphetamine and cocaine. So that's how cocaine works. The way that opiates work, it's a little bit different. So it goes through the mu opiate receptor, and it has then a negative feedback loop through the GABA receptor. But at the end of the day, the opiates, heroin, fentanyl, prescribed opiates, they manufacture more dopamine and put it out into the active part of the brain, the synaptic cleft. So 2 substances, but we could do this with anything. We could talk about alcohol or cannabis or nicotine or sex or gambling or sugar, right? We could talk about any of the known addictive substances or behaviors, and it would impact some pathway here. Some of the pathways are really complicated. I'm not going to deny that. So your brain, used to knowing 100, 150, 200 on a good night levels of dopamine, when it starts to see these levels of 900, 1200, it says, holy smoke, something is wrong. And it starts to downregulate. It stops making dopamine. It starts erasing the dopamine receptor on the other side of the synaptic cleft, and it starts turning on the vacuum and sucking out the extra dopamine. So it's not just your spike crashing, you're actually getting brain changes that make your level of survival neurotransmitter called dopamine so low that you can barely function. And it's not just that you're sick, you're living in this miserable place, and the only way to feel normal is to continue to use. And if I said to you, the only way for you to stop being miserable is to continue this behavior that doesn't even work to get you high, but at least it makes you normal so you can go to work or take care of your kids or clean the house today, most of us would actually continue with the substance. We would. I mean, I think about one of the reasons I do this work is I consider myself the same as every one of my patients. I struggle with my own substance issues. My substance of choice is not one that's going to incarcerate me, and it's not going to kill me, but it's sugar. I'm a sugar fiend, and I've tried to stop eating sugar or really decrease the use of sugar. Sugar is really bad for your health. It makes a lot of us really highly inflamed. It causes weight gain. My arthritis is a lot worse because I eat so much sugar. I know this, and yet I have a hard time controlling my sugar intake. I am not comparing fentanyl to sugar because people are dropping dead from fentanyl, and my sugar is not killing me. It's making me less healthy. But the point is, all of us struggle with some behavior that we're having a hard time changing. All of us are. So my hope is by the end of this, some of us have less judgment towards others, because so much of all of the what I learned in medicine is we really made people who struggled with addiction feel terrible, and you should get over it. Stop using, pull yourself up. You're being an idiot. Like all the feelings we've had. If it were that easy to stop, people would just stop. It is one of the hardest chronic diseases that I take care of. And I want to tell a story about this, something that likely happened at Bay State Franklin or Berkshire Medical Center today. And this is a story that I'm going to tell about this gentleman here on the upper left of the screen who woke up this morning, 5 a.m. He said to his wife, "I don't feel so good. I'm feeling a little short of breath." And he's clutching at his chest. And she looks at him and thinks, "Holy smokes, you look terrible." He's ashen. He's clearly short of breath. And she's concerned. So she calls 911, and they arrive in his living room and take a look at him, and they put some oxygen on, and they get his vital signs, and they hook him up to an EKG that gets transmitted and is read by one of the local EMTs and transmitted to the hospital. The guy's clearly having a massive anterior wall heart attack. He is not okay. And they think to themselves, where are we going to bring him? Because he not just needs a cath lab warmed up, he may need open heart surgery. So they end up getting this guy down to Bay State fast. And they bypass the cath lab and they bring him to the operating room. And this guy ends up with a quadruple bypass. He's very sick. He nearly dies in the OR, but he is saved. He is brought to the cardiac care unit for several days. He's brought to the floor for maybe another week. He's well enough that they decide to send him home without going to a skilled nursing facility, but that was touch and go as well. And he ends up having 12 weeks of cardiac rehab. And he's actually doing great now. He's fine. I want you, don't answer the question right now, but I want you to ask yourself how much money just got spent on him, okay? His next door neighbor, also this morning, very early, is a young woman who went to college. She was a first generation kid, graduated from Turner's Falls High School in Franklin County, and she went to college and was a soccer player there and hurt her knee quite badly and ended up with multiple surgeries, got pretty depressed, was prescribed quite a bit of opiates during that time. And she realized she really felt better when she was using opiates. It made her feel happier. It decreased some of her depression and sadness about losing her sport of soccer and possibly losing her scholarship. And it didn't take long before she realized she had actually developed an opiate use disorder. And doctor cut her off, prescribed opiates. She didn't know what to do. She began buying what she thought were perk 30s on the dark web. They're not perk 30s, they're really fentanyl. She's had a couple of bad overdoses because of it, but she's been doing pretty well. She's been going to a Suboxone clinic or a buprenorphine clinic for the last couple of years. She's been very stable. And yet her mother, when she knocked on the door this morning and found no response behind that door, her mom busts into that bathroom to find her daughter lying blue on the ground. Her mom's a smart mom who loves her girl and has Narcan available at the home. And so she called 911 first and administered the first dose of Narcan and then the second dose of Narcan. And by the time the ambulance gets there, they really are having to pile through all of their Narcan and get her to Bay State Franklin Hospital, where she's not treated particularly well. In fact, she's back breathing again. She's back to life. And mostly she felt shamed and blamed and embarrassed and a little bit sick. And her mother's so distraught, she feels guilty. And yet she was somebody who's doing really well. So I want to go back to her neighbor, this guy with a massive heart attack. First of all, you can either unmute yourself and shout out a number or maybe write it in the chat how much money you think got spent for his quadruple bypass, his 2+ weeks in the hospital, including a cardiac care unit, and then his cardiac rehab. Anybody have any guesses?
I'd say at least over $100,000.
Yeah, Sue Keller with the $250,000. That's the number I'm going for too. I think about $250,000. Could be a little less because Bay State's not a super expensive hospital, but yeah, you guys are all in the right range. A lot of money got spent on this guy. And I want to tell you a little bit more about this guy. He is a fellow who's not especially healthy, right? He's 62 years old. Both of his parents had cardiovascular disease at a fairly young age. He used to smoke 2 packs a day. He's done great. He's down to a little less than a pack, which is awesome. He kicks back, I don't know, 4 to 12 beers many days a week. He likes to drink with his friends. He goes to a fast food restaurant a couple times a week. Did he create his heart attack? Did he have some behaviors, including some addictive behaviors that led towards this?
He did.
He did. Yeah. I mean, I actually would argue absolutely he did. The number one cause of death in our country is tobacco. Tobacco causes cardiovascular disease and cancer. He also drinks in excess, period. And we all know that alcohol causes significant disease states in many organs beyond the liver, including the heart, and it's one of the leading causes of cancer. And he didn't eat well, and he didn't take care of himself. But nobody, when they rolled him into that Bay State ER, looked at him and wagged their finger and said, look, dude, you created this problem. You caused this. Your bad decision-making created a heart attack. And so we're going to give you a giant shot of shame and blame and make you feel bad. And we might not give you great medical care today, right? Nobody did that. This guy got, standard of care, which is pretty awesome if you live in a well-insured, well-hospitalized, high-functioning state like Massachusetts. He got the care that he deserved, which was the best care possible. And yet she really didn't get that care. Because what somebody could have said to her, a recovery coach in that ER could have looked at her and said, hey, I know how well you've been doing. You've been doing great, right? You've been going to a buprenorphine clinic. You just got a job. I know this because I talked to your mom in the waiting room. And she loves you, and she's upset because you scared her. But my understanding is you got your first paycheck this morning. And sometimes that first paycheck is a real problem for people in early recovery because it's a thing that they've never learned to manage money well, and it burns a hole in their pocket. Before you know it, you're buying stuff again. And relapse is a common thing. Return to use is common when you're in early recovery. It's expected, and it's not a time to beat somebody up. She doesn't need to be beating up anybody in medicine. She's doing that herself. You don't need to make an addict feel bad. They already feel bad. So actually bolstering her there and saying, look, I'm worried for you. I'm wondering how long has this been going on? My guess is you're now using fentanyl because that's all that's available now. Sometimes the dose of buprenorphine you might have been on previously isn't sufficient. Maybe we need to change that dose. Let's spend some time thinking about how we can help keep you safe and alive. That's what should have been given to her. And in most ERs, I'll be honest, in most ERs in Western Mass now, that level of care is being delivered. But I would have said to you 3 years ago, it wasn't. Now, I actually think for many people, they're getting good quality care and respect and acknowledgement that it's a deadly disease, especially today with the level of poison available to people. I am going to pause for a second and just say, I told a story about how it is that the brain develops addiction that feels pretty easy, that you could go explain this to your grandkids or to a middle school. The substance cycle is actually really complicated because it doesn't end when somebody walks out of a detox. Like actually it doesn't, that's just like the beginning of their management of their chronic disease. That the cycle of substance-related disease is this cycle that goes on for years and years. And I know this because I watch it in the jail. So I take care of 160 inmates, 80% of whom have their initial offense is substance-related. Many of them have a substance use disorder. And, when people come to jail, almost all my people are smokers. There's a high tobacco use disorder with people who are incarcerated. But when you're incarcerated anywhere in the country, there's no smoking. It's not like the old days where people brought in cigarettes. There is no smoking. You become an immediate non-smoker. And yet almost no matter how long you're incarcerated, whether it's 6 months or 2 years or 5 years, what's the rate of return to cigarette smoking? It's almost 100%. right? You would look at somebody and be like, dude, you've been in jail for 5 years. Why are you smoking? What happened? And they look at you and smile and shrug their shoulders. And the reason that people return is this cycle of I'm preoccupied, I'm anticipating, I'm thinking about my release, activates the brain again. So you enter back into the cycle. This could start at any point in recovery. People in long-term recovery will say, I hadn't had a drink in 10 years. And then a thing happened that made me feel very similar to the way I felt, 15 years ago when I started drinking or when I began drinking heavily. Often it's a tragedy. Often people will say, I was doing great. I was doing so well. And then my mom died, or one of my kids died, or COVID happened and I had nobody and I was all alone and I was scared. And any number of things can start you down the cycle in this pathway again. It's extremely common. So this is the complicated definition of addiction. It looks like an older definition, but it's actually one of the more updated ones from the American Society of Addiction Medicine. And I'm not going to read through this whole thing, but I am going to cover some of these segments. It has with it a real disruption of healthy supports and big problems and interpersonal relationships. That is a big thing that happened. And it's why having a supportive recovery community is so important. There does tend to be a very strong co-occurring psychiatric illness. You have to be able to treat all of that as well. There tends to be impaired executive function, so that perception, learning, impulse control, compulsivity, and judgment are impaired. We talked about that a little bit earlier. I never can remember all of these bullet points. My brain can't hold that much information. So when I think about addiction, I actually always think of what are known as the 5 C's of addiction. And the 5 C's of addiction are compulsive use, loss of control, continued use despite harm, and having cravings. So some patients will be sent to me with the question of, do they have addiction? I'm an addiction expert, so I can usually sit with somebody and hear their story and then repeat it back to them in a way that says, I actually don't think you have substance-related disease based on what you said. Or I'll say, let's talk about the story you just told, the places where you lost control, that you've had continued use despite harm, compulsive use, or cravings. You don't need all 4. You really take one to make the definition of having addiction. So who's going to develop addiction? Well, we don't always know. Not everybody who uses illicit substances is addicted to them at all. And in fact, there's many more people who actually use substances that don't have an addiction than do have an addiction. And yet we judge it all the same. About 70% of people who use cocaine use it actually intermittently, lightly, recreationally, and really 30% or less actually have developed a cocaine use disorder. So, I'm not one of those people that says, if you use this once, it will kill you. Actually, I will say that, because if you use fentanyl one time and you're opiate naive, it actually can pretty fast. But it's not as though everybody who is exposed to a substance becomes addicted. And we can ask ourselves our own personal question about that, because many of us on this call have used substances. Many of us on this call drink alcohol. And yet many of us in this call do not meet the definition of having an alcohol use disorder. That's just a common example. But there's 3 things that really can predispose you. And this is important for those of you that work with kids or young people to really talk about it. So genetics, early exposure while your brain is developing, and a history of childhood trauma. Having poor mental health does not necessarily create addiction. It can lead towards addictive behaviors. What it does is it can lead towards some of the things that I just described. So when you're struggling as a teenager, might be these days with terrible anxiety or depression or loneliness, you find yourself feeling a relief from that pain when you use marijuana as an example. You're 13 years old and you're doing marijuana once a day, twice a day, 3 times a day. You're somebody whose brain is being exposed to an addictive substance while it's developing. That's what can lead to addiction. So poor mental health alone doesn't mean you're going to have addiction, but if you are coping with your poor mental health by using addictive substances, that's what leads towards it. So the genetics are big, and I care about genetics, not because I do genetic testing or know how to interpret genetic testing. I don't know how to do those things, but because I'm a family doctor, I sit in the room with families, and I often will take care of generations of families. And I actually know the substance story within the room. And I'll talk to the 9-year-old actually about substances. I would talk to a 5-year-old about a substance. And a 5-year-old conversation about substances is something simple, like If you ever see a pill on the floor, you go get an adult immediately. You don't pick it up. You don't put it in your mouth. You get an adult immediately. That's what the conversation you would have with a kindergartner. That's a substance related talk. What would I say to a 9 or 10-year-old? I would say, look, do you know that actually many people who have addiction now started using their first substance when they were 10, 11, or 12? That is the most common age of first use for alcohol, marijuana, or nicotine. And if you don't talk to them before they hit that age, then you're actually missing the boat. The other thing I'll say as a family doctor is I will say, look, I know how hard things have been for you and your family. I know that because you've told me how hard it's been. And I know that one of the things you told me at one point is you're worried that you might turn out like your mom. And I'm telling you that the one way you can protect yourself, because you don't get to change genetic history, is you can actually have a big, you can turn this giant ship around by delaying the exposure to a substance. So right now, genetics accounts for about 50% of the risk of addiction. So a strong genetic risk puts you at risk. It's not set in stone, but you should be concerned about it. We know that all addiction is considered a pediatric developmental disease. It is very rare for me to sit in a room with somebody who did not start while their brain was still developing. Now, I'm not saying that I have everybody using heroin or fentanyl at age 13, but they will say one of the 3 most common ones, nicotine, alcohol, and cannabis, started while the brain was developing. And again, the average age is 12, 13, or 14. But I've had people tell me I started using when I was 6 years old. I started smoking cigarettes at the age of 6. My dad thought it was fun to get high with me. So by the age of 8, I was using marijuana. My mom was passed out every night in a chair with a handle of vodka next to her and a vomit bucket on the other side. And I thought, well, she's having fun. Maybe I'll join her. So if you actually spend time asking people about when they were first exposed, it's incredibly young. This is the stuff that should be taught in health classes, right? Like there's a lot of stuff that should be taught in health classes, but talking to our kids about how to protect their brains from addiction is one of the most important things. We spend a ton of time on concussions. I'm all about protecting head injuries. I like that idea, but this stuff matters. And funding health education in our public schools and our private schools, it really, really matters. This is a study, it's kind of an old study, it's from the 1990s, but it looked at 15-year-olds starting drinking. And the definition of drinking in that study was 2 alcoholic beverages a week. So not much, but it didn't matter. They're 15 years old. So having 2 alcoholic beverages starting at the age of 15, 40% of those kids went on to be alcoholics. The national rates of alcohol use disorders are way lower than that. So in this study, if you waited to be exposed to alcohol till the age of 21, only 7% went on to develop an alcohol use disorder. So if you had a kid sitting in front of you who you knew or they knew had genetic risk, what you would say to them is you can change this. You can protect your brain and actually work against any genetic risk you have by postponing your use of everything. Just wait until you're age 21, 22, 25, wait. And it's extremely uncommon to meet somebody who never used a substance prior to the age of 22, 23, or 24 who has an addiction. Is it 100%? No, but it's right up close to 100%. It's protective. You ask yourself, well, maybe the legal age to buy cigarettes or alcohol or marijuana, maybe it should be higher than 21, right? It could be. I mean, these are just laws. These are things we set in place. I don't know. I mean, I see the age of us on this call. I mean, I grew up out here. And I remember when alcohol legal age was 18, right? I'm sure you guys remember that too. We used to drive to New Hampshire to buy alcohol because it was 18. It was really frightening to think about the 1980s and how much driving and drinking at the age of 18 that was happening. So the third thing that puts you at risk for developing a substance-related disorder is having a high ACE score or high childhood trauma. And this, everybody knows about ACE scores. Everybody knows about traumatic childhood and what that means. And I don't want to bore you with that, but I just think people should really know what this means. If you are a person who is highly traumatized and hasn't found a way to manage or mitigate that trauma in your life, you're going to want to escape it. You're going to want to escape the pain of it. And there's nothing that allows you to escape better than, I think my 2 favorites would be alcohol and opiates. They really allow you to escape the pain for a while. And patients will tell me that I started because it allowed me to not feel, and I needed not to feel. So I want to remind everybody about the origin of the ACE study, the Adverse Childhood Experience Study. It actually was 1997, I think, or 1996. It's a really interesting origin story. I was a resident at Boston Medical Center. It was the 1990s. I was working with a gastric bypass surgeon, and we took care of people who had BMIs of like 70. These were people who were 600 or 700 pounds. They were like copter vacked in through the roof. It was crazy. And he would say to me, every woman you meet today will have been sexually abused as a child. And I was like, really? What? Is this known? He's like, I don't know if it's published, but this is what I know. This is what the surgeon said to me. And the study was done actually to investigate that. Is there an association between massive adult obesity and childhood sexual abuse? That was the real question that was asked. Really what they did is they took 17,000 patients at Kaiser, and then they asked 10 questions to them. And then they were able to compare it to other patients at Kaiser and just to look at the disease states associated with having a high score on an ACE score. So an ACE score, I actually think most of us should know what our ACE score is. It's a common series of questions. I asked the patients. It's a screening tool at the jail. And it's stuff that you guys know. And I'm going to read a little bit of it. I'm not going to read the whole thing because you can go back and read it or read it now. But did a parent or another adult in the household often or very often swear at you, insult you, put you down, or humiliate you, or act in a way that made you afraid you might be hurt? Did a parent or another adult in the household push, grab, slap, or throw something at you, or hit you so hard that you had marks or were injured? Were you ever sexually abused? Did you often or very often feel that no one in your family loved you or thought you were important or special? Your family didn't look out for each other, feel close to each other, support each other? Was there somebody in your household with major mental illness or suicidal ideation? Were your parents divorced or separated? Was there somebody in your household who's incarcerated? 10 questions, yes or no. And I do this on myself, and it's a test that's asking you to reflect upon what happened to you under the age of 18. It's not meant to be given to children. Children shouldn't reflect on their lives, but you give it to an adult to reflect on their lives. So I score a 1 on an ACE score. My parents were divorced, but otherwise I had a great, happy, loving, safe childhood. But many people that we know and many people we care for did not have that. And if you can imagine, my hope is that many of you on this call do score low on an ACE score. Having said that, I think statistically speaking, a lot of you actually score 2, 3, or 4 on this. When you look at the average scores at a jail, our average score is 7. I've had people routinely score a 10. You ask yourself, no wonder you're locked up, right? There's an expression we use in the carceral system of hurt people, right? They had no model of what it was like to be like a high functioning adult that didn't just wreak havoc on other people's lives. That was their modeling, and that's what they ended up doing. So if we're not treating trauma in jails, well, I don't know what we're really supposed to be doing, because that is what is going to stop people from hurting other people. It's a hard thing to do. So having a high ACE score, having a high trauma score is one of the 3 things that is going to set you up for developing a substance-related disorder. And if we don't treat trauma in our communities, we're going to just have more and more people get addicted. Now, this is an old score. There's many scores that we can do differently. In fact, before this talk, I was thinking about it. There are community-based ACE scores that look at racism. I mean, the ACE score as an entire community for the native peoples of this land is appalling, right? Their land was stolen from them. Their people were raped and murdered. They lost everything. And ask yourself about your personal knowledge about the addiction rates of the native populations in this country. It's the worst, right? And a lot of that is based on generations of trauma. If I ask my daughters who are, 19 and 21 to put together a trauma score for today's kids, I don't know, start listing them. Columbine, hiding under your desk, preparing for a mass shooting, every 3 months in your facility, lockdowns. None of us on this call have lockdowns, right? We did not, but our children do and our grandchildren do. And those are traumatizing. When you look at how much our kids are suffering right now with anxiety, depression, suicidal thoughts, you think a lot of it isn't coming from this. Again, we can list the number of catastrophic, including global warming catastrophes that our kids are facing, that is traumatizing to them. And, it would predict for worse substance-related disorders in the future. I'm going to talk about alcohol. I think people think I only know about opiates, but alcohol is actually it is the most harmful substance outside of tobacco. And it harms a lot of people. And I think many of us either don't drink or we drink very little. That's most of us, but a lot of us drink a lot. So the top 10% of Americans drink on average about 74 drinks a week. That's a lot of alcohol. Now, that's what studies would say. I take care of people with alcohol use disorder. So I feel like everybody I see, that's normal, right? It's normal for me to take care of somebody who says, I drink a handle of vodka a day. A handle of vodka, I mean, I had to go to the liquor store to look up what all this stuff meant. But that's a lot of alcohol. And for those of you that pick people up on the curb or bringing people to the emergency room, I think a lot of you have taken care of people who are under the influence and they have a lot of substance, particularly alcohol. You guys know this because you're smart, that what does it take to be a drink? It's not very much, right? It's just 5 ounces of wine. And I actually recommend for those of you who drink wine, you should measure what's in your wine glass. And I mean that, right? Like put 5 ounces in your wine glass, acknowledge that's 1 drink. If you want to have 10 ounces, fine with me, except that's 2 drinks. You've got to be honest with yourself. And one of the things we see is there's nobody who's been sort of sold this bogus bill of goods more than women. Women in the last 10 years have really sort of headed down the path of developing an alcohol use disorder because it's being sold and marketed to women as one, it's good for you, it's healthy, it prevents, heart attacks or whatever it is that's said. And it's just, it's used for managing the stress of parenting and working and running a household and being a dog parent and all the other stuff that a lot of us do as females. And the other thing we'll say about alcohol in women is women are harmed at a much earlier age and much more severely. So I've had 32-year-olds die of alcohol use in front of me. I didn't think that was possible, but that's what it looks like in a woman. Alcohol is more harmful than heroin or crack. This is a really important article that comes out of the UK, and it comes out of a paper that was published by David Nutt. And it's a really interesting paper. It's worth going back to the Lancet to read it. But what it does is it looks at all the substances that we all think of. They're all the illegal substances with the exception of tobacco and alcohol. And it asks 2 questions. What is the harm to other people and what's the harm to the user themselves? Alcohol's harm to other people is really high. And the harm to the user also really high. And when harm to others, you might ask yourself, well, what does that mean? Well, it's everything. It's not just driving drunk or having a bar fight or hitting your partner. A lot of domestic violence is alcohol related. It's also just not existing for your kids because you're drinking too much. It's the developing fetus who has fetal alcohol syndrome. Its harm to others is significant. The harm to others with actually heroin or fentanyl is much, much lower. It's harmful to the body of the person who uses it, but harm to others is actually much lower. At the bottom of this is stuff that might surprise you or not, but the actual psychedelic drugs are not particularly harmful either to the user or to the people that use them. So mushrooms, LSD, ecstasy, which is MDMA, are actually not especially addictive. In fact, particularly not addictive, and they're not particularly harmful. Did somebody have a question? Okay, I think I heard somebody. I don't want to miss a question. Christy, is there anything in the chat that I should be looking at? Not yet.
There have been a couple of comments as you're going along, but no questions in the chat yet.
Okay. This came out today in the New York Times. I just threw it in there because there's a great video. It's absolutely worth going to today's New York Times, probably online under the video section. The videos, actually, the topic is what would happen if we taxed alcohol. And again, this graph, I was like, oh yeah, this is what I know, but boy, does it demonstrate it well. So yeah, tons of people are dying from opiate overdoses, but not even close to the numbers that die of alcohol. And guys, look at how much the alcohol has gone up. And this ends in 2020, right? The drinking that started during COVID was crazy, and people were scared. They were lonely. They were locked in their house. I have a good friend who runs liquor stores, and I remember in 2020, he said, every day is Super Bowl Sunday. I'm doing fine. And I just thought, wow, this is not good for the health of our nation. So what makes people better with addiction? Many things make people better. But one of the things I'm going to say is time. It takes a long time to get better. It's not going to, the Breen Center, Franklin Recovery Center, or McGee, and being there for 10 days that makes you better. And if anything, quite honestly, those 10 days can be dangerous because you get off of whatever you're taking, your opiate receptors are now sitting empty. And then if you go back and use, your rate of overdose is much higher. So a lot of us that work in the addiction field spend a lot of time trying to stabilize people in treatment. But people get better with time, and it isn't a week or two or a month or two. It's actually years it takes to get better when it comes to substances. So this is just a PET scan looking at the brain. These are people exposed to cocaine. Those top slices of the brain are normal brain activity. And then the middle row is people who are 10 days abstinence from cocaine. So they're 10 days away, which is awesome. They walked out of the detox center, and that's what their brain looks like. It does not look like the top row, not any way, shape, or form. And the bottom row is 100 days later. So over 3 months later, their brains are better, but they're not great yet. And you've got to give people time to get better. And one of the things I have a lot of pride in is that in Western Mass, we have a lot of good quality treatment, and we have the full spectrum of treatment where people start at the detox level of care, and then they go to CSS or TSS and long-term residential programs. And you can be in treatment for 1.5 years or 2 years, almost all paid for by the state, which is really beneficial to people. So this is also an older graph, but it compares what we call relapse or sort of not doing well rates among other chronic diseases. And again, I'm a primary care doctor. I know what this looks like, meaning that when people come to me and they have high blood pressure or asthma, and I say, well, how are you doing with management of that? Because the management of hypertension isn't just taking your pills every day. You could actually improve your blood pressure in all kinds of ways. You can exercise every day. You could stop drinking. You could stop smoking. You can increase the potassium in your diet. You can decrease some sodium. There's like 10 things you can do on your own, if you wanted to really make a big difference in your blood pressure. And you could take your medicine every day. Now, 50 to 70% of people with high blood pressure don't do that at all. In fact, most of them don't do any of the changes, and they might take their medicine half the time, right? We don't fire them for that. We don't even judge them. We sort of acknowledge it's a fact. People with asthma, I'm like, so do you use your preventive inhaler 2 puffs every day? And they're like, which one is that? And I'm like, oh, they're definitely not taking their preventive inhaler. So even though we've said, look, there's one that's an inhaled steroid, the other one's a rescue inhaler, you probably need both of them. People don't manage their chronic diseases well. It's not any different with addiction. I mean, people get better and then people take a step backwards for any number of reasons, and they get better again. And so I really work hard in my own head, and when I'm teaching residents, to have them consider this a chronic disease with a lot of ups and downs like we do other chronic diseases. You guys know this because you're super smart, but really the first overprescribing wave of prescribed opiates really started in the late 1990s. So OxyContin came out from Purdue Pharma in 1996. And between 96 and 2005, those Purdue Pharma reps were everywhere. My meals were covered by Purdue Pharma when I was a resident. That was the first overprescribing wave. In 2010, they reformulated OxyContin, so it was much less abusable. You couldn't really crush it. It sort of became this gummy stuff. It was a lot of work to get it out. At that stage in 2010 is when we start to see heroin take over. And heroin is much stronger than prescribed opiates. It's much deadlier. The way that people are going to use it is just less safe. It's an unsafe drug supply. So you see the second wave of people dying is from heroin. And then in 2016 is when fentanyl takes over in Massachusetts. In other states, it was much later than that, but really in 2016, fentanyl becomes the predominant drug in the drug supply. And at this point, 2019 through now, there's nothing. It's all fentanyl. We fentanyl test everything, but you tell a patient they have fentanyl, they're like, of course I have fentanyl. It's fentanyl mixed with other horrible stuff now, but there's no more real heroin available in this country. You guys know this also because you're really smart. Fentanyl, 50 to 100 times more potent than heroin, and it's tiny. The amount you need to overdose is the tip of a pencil, right? That's all it takes to overdose if you're opiate naive. So getting this into this country is super easy because it's tiny amounts that you need, and it's going to be very hard to shut down the way it comes in. And because it's cheap and it's being manufactured mostly now in Mexico, it is being cut into everything. So when I say perk 30s, there actually are no perk 30s. There've never been a perk 30. I went back into the formularies back in the day, that formulation didn't exist. So that's what we call a Percocet or oxycodone 30 milligrams. All perc 30s are fentanyl, period. We know that because we test it. So if somebody ever says to you, I'm using a perc 30, they're using fentanyl. And I think you guys know this because you read things and you're knowledgeable, but the One Pill Can Kill campaign is a DEA campaign. There's another great campaign that's called Drop the F-Bomb, and it's about talking to your kids about fentanyl, because kids are dying because they took one pill, right? Some friend said, look, I know you're taking the SAT tomorrow. This Adderall is really going to help you get through it and get to college. And then they take this one Adderall, which isn't Adderall, right? It's a fake Adderall that really has fentanyl in it. One time for one person who does not have an opiate use disorder will kill them. And there's, one of those New York Times stories that left me in tears was telling the stories of young people dying because they do not have an opiate use disorder. They just used a fake pill once. So this should be taught in all the schools too, right? So there's two campaigns, One Pill Can Kill, and the other one that I really like, and I like the graphics, is Drop the F-Bomb. It's about talking about fentanyl use. If you guys don't know, I'm a public health person. I love looking at sort of demographic data, but when you look at, there was a real shift that happened in the last 10 years about what was the leading cause of accidental death in adults, and it's opiate overdose. The numbers have just gotten worse and worse. So heart disease and cancer run neck and neck for number one and number two for dying, 1 in 6 or 1 in 7, depending on what state you live in. They flip back and forth. COVID-19, 1 in 10 deaths are caused by COVID-19. Obviously, that's new data. And then opiate overdose, 1 in 58 people will die of an opiate overdose. Those are incredible numbers. I mean, those numbers changed in the last 2 years. They changed in the last 4 years, and they're getting worse. I don't think, my understanding is there's been a slight plateauing of opiate overdoses right now. But it's a massive problem, and it outpaced motor vehicle accidents long ago. I do want to just make a comment about kids, though. The leading cause of death for kids, despite what I just said about fentanyl, is not opiate overdose, it's guns. And I think you guys all know this. The CDC just came out with this data, but the number one cause of death under the age of 18 is a bullet. And when you look at, it used to be motor vehicle crashes by a big margin, and that data goes back to the 1990s, but we made cars safer and we made kids getting strapped in the law, and kids don't die in motor vehicle crashes like they used to. And instead, we allow country and rules that kills our kids. So no wonder our kids are suffering right now. So what does it take to get better from addiction? Well, it doesn't take one thing, right? It doesn't take, one drug. It doesn't take one meeting. It takes a lot of things to make people better. And we need to develop communities where all of these are available. So this is a pie graph of some things that make many people better, but there's pie graphs that are much more complicated that make people better. So when I talk to a patient, I run methadone clinics, I run buprenorphine clinics, I have both those medications available at the jail to anybody who comes in. We both start people and continue people. But I talk to them about, one of the things that makes you better is having a sense of purpose, doing something on this planet that makes you feel good, building your self-esteem, learning to love yourself again. Those are like the late comers to the getting better pie, but they make you better. Getting good treatment for your mental health disorder, having a job, giving back, living in a house that's stable and sober. If you're sleeping under a bridge in Holyoke, you're not going to get better. It's not your fault. But if I were sleeping under a bridge, I would use cocaine all the time because I would want to protect myself. And women will use cocaine so they can stay alert enough so that they don't get assaulted. That makes sense. And if we were able to house all of our people, that's like 50% of the game of getting better. I think this grant that you guys are working on doing complementary treatment and body therapy and meditation and other things is going to go a long way to help people get better too, because that allows people to be present in their body. And so much of using drugs is, dipping and dabbing and running, and you're escaping your body, right? That's your intention, because being in your body and being in your mind feels so bad. But actually getting to the other side and working in early recovery or middle recovery and learning what it feels to stay present in your body and have that be okay and have that be a safe place. These are people for whom that's never been a safe place. So when you guys are recruiting your body workers, et cetera, you really want people who know how to work with people with trauma, because I guarantee you, everybody you will be working with have a high trauma history. Again, you guys are smart. I don't need to go over this. There's medication that helps people with treatment. I wish that the medications for treatment were better when it came to nicotine use disorder and better when it came to alcohol use disorder, but we use them all the time. Every day I offer people the 7 medications for nicotine replacement. Do people quit smoking easily? Absolutely not. Do those meds help? They help a bit. For alcohol use disorder, we have a list of things, but at the top end of that list is naltrexone, and probably it helps about 25% of the time. Opiate use disorder, we have miracle drugs, drugs that make people feel so much better, make them feel normal, and can steer them into a life that's not chaotic, and they have control over it again. So there's 3 of them, but it's really the 2 opiate-based ones, methadone and buprenorphine, that are really the most effective. And they are considered the standard of care, first-line treatment. If all you do is get somebody a medicine, that's a big chunk of the game. And we live in a fine state that not only mandates every insurance company pays for this kind of treatment. In addition, we have the Expanded Affordable Care Act that mandates payment for treatment for buprenorphine and methadone. We have it pretty widely available at this point. Actually, Berkshire County is a funny county. It's a big county. I don't need to tell you all that. It runs north to south. There are 2 methadone clinics in the entire county. There's a lot of regions in Berkshire County where getting to a methadone clinic is near impossible. I am a big national proponent on changing the methadone regulations to allow it to be prescribed at a pharmacy like every other medicine. There's a bill in Congress sponsored by our own Senator Markey, so that board certified addiction doctors could prescribe methadone to a small pharmacy so that somebody in Cummington could have access to it. Right now, getting to a methadone clinic every day is very challenging. I covered this a little bit. So which treatment for opiate use disorder is best? Whichever one works for a patient is the best one for them. So this is just a chart that sort of talks about sort of how one might use them, but I use mostly buprenorphine and methadone. I sometimes will use naltrexone, which is also known as in its injectable form as Vivitrol. I use most injectable naltrexone for alcohol because that's where the efficacy is the highest. So I have a website. It's just my name. If you Google my name, this website will come up. And on this website are articles that I've read or I found interesting, and videos that I thought were interesting. And some of it feels, I try to update it. But during COVID, this got quiet because I was busy running COVID World, like everybody else on this call. But anyway, there's a bunch of stuff there, and anything that's new and hot and happening goes there too. So if you want to ever go there and get more information because you want to learn more, that's a good place. I have a section on good books to read that is also pretty updated there as well.
Dr.
Okay,
Potee,
yeah.
We had a question in the chat about whether there are medications for use with meth.
Yeah, there's no medication for any of the stimulant use disorders, including methamphetamine or cocaine, none. They've done a lot of studies on them. Like we've looked at naltrexone and Vivitrol, both for cocaine and methamphetamine. It didn't have much effect. There's some studies that look at using stimulants to treat stimulant use disorder. And patients will say that to me. They'll say, my number 1 struggle is cocaine. It's wrecking my life. It keeps getting me locked up in jail. And I'm fine. I come to your methadone clinic. I haven't used an opiate in 2 years, but my cocaine use is out of control. And that's a person for harm reduction reason. First of all, you guys know cocaine has fentanyl in it now, right? It's all cross-contaminated. And here I have somebody who's not opiate exposed. She is because she's on methadone, but the risk of being exposed to cocaine that has fentanyl in it is high. People will die. People are dying. So using stimulants like Adderall or Ritalin is actually evidence-based for treating stimulant use disorder. Now, does it make people nervous? Sure, it does. Will I do it? I do it sometimes because I am constantly weighing the risk and benefit of everything I do. And compared to the illicit drug supply, which is so incredibly toxic, I know whatever I'm offering them is at least an FDA-inspected safe drug supply. And we're never going to have legal drugs in this country, not that I can see. And yet, I know that what is offered from a pharmacy is a lot safer than what's out there. So yeah, no easy answer for stimulant use disorder. We all wish that there were. an easy answer there. And again, it's a place where contingency management does make a big difference. And I don't know who's doing contingency management sort of system-wide in Berkshire County or even in Franklin County. There's not many people do it. It's a lot of effort. So you guys know a little bit, it tend to be group settings. You know where we do it? We do it at the jail in Franklin County. So group settings where you are rewarded for not using, and the rewards are little. They're like a pat on the back. You draw out of a goldfish bowl. People like to be rewarded. Like people go back to get lottery tickets, one, because they think they're going to score big, but also they like the little $1 things, right? That keeps them buying lottery tickets. So contingency management is very evidence-based. It's paid for by Mass Health. There's a lot of online apps that do contingency management, and they literally put money in your bank account when you're not using. Okay, so Christy, can I rely on you to maybe ask questions out of the chat, and then people who want to also ask questions to just unmute themselves?
Sure. We have one question now asking if you know anything about Worcester County.
The entire county or the jail?
It just says Worcester County. Maybe James can unmute and ask. James, are you able to unmute and specify what you were asking about?
How about we come back to James, or he types it in the chat, because maybe he's having audio issues if there's.
Sure.
Because I could answer that, but I'm not sure what we're talking about.
Does anyone else have any questions? Vicky, is that your hand up? Go ahead and unmute.
I'm real curious about practical application here as a everyday citizen. So this morning I was going to a class, and I work with some of the homeless people that show up to the library regularly, and the library here has had a continuing concern with the behavior and how to deal with it. How do you interact with them? How do you help them make socially acceptable choices, even though they're intoxicated or whatever their addiction is in the moment? But like the one I was working with this morning, the police started to come around, even though his behaviors were just like dancing. I thought he was just dancing. So I just went over, and I knew him from my work at the library. And I just, hey, how's it going? What's going on? And police came, and I said, what drew your attention over here? Why did you come? Oh, we just saw him acting a little strange, so we just thought we'd come and check on him. Because the stories I hear from the library, and of course some are exaggerated, I get that, but is that too many people escalate it by the way that they interact with them, like judging them or being afraid of them. And I'm just looking for good strategies, because the person that I was with said, I want to learn how to do that. I want to learn how to interact with them when I see them on the street. I don't know where you learned that.
Yeah. Well, so first of all, I'm going to a couple comments, Vicki. One is some people that you're working with may or may not have a substance use disorder. There's a lot of people who are unhoused with significant mental health disorders that are not managed, not treated. And, there was an upside to closing down all of the residential psychiatric programs in the state. How many decades ago did we do that? 25 years ago? There was a real downside too, because a lot of people with major mental illness are either locked up or they're unhoused. And it is different to be under the influence of a substance, actively under the influence of either alcohol or methamphetamine or cocaine, let's say, or having visual auditory hallucinations or another psychotic episode. So in your community, I'm just trying to think about who does these trainings, but we do crisis management and de-escalation trainings throughout mental health organizations all the time. And I think many of you work for mental health organizations, and you've been required to do these de-escalation things. I feel as though, I don't know if MRC does those kinds of training, Christy or Corinne, but they're really good trainings about how to de-escalate circumstances that are causing you concern. I will say also, Vicki, that just treating people like human beings, that's really that's what we all are. And a lot of us have been in incredibly distressing stressful circumstances, where we're not in our right minds. And yet I feel for the libraries, Pete, right? Libraries are a safe, warm, protected place with running water and toilets where people who aren't housed can go. And I'm so grateful that the libraries, they didn't want to serve that purpose, but many of them are stepping up. Many librarians know how to use Narcan and know to check the bathrooms because it's a common place for people to overdose. So I would actually argue that actually librarians and people that work at 7-Elevens and people like many people who do street work doing crisis management and de-escalation techniques can really help. So Christy, Corinne, do you guys know who does those trainings in Berkshire County?
We've worked with the formerly they were the Training and Mediation Center, but it's more like mediation / de-escalation. So, but otherwise, no, I don't.
Just a caveat on that, because last week we had the library asked for help because it's become such an issue that the regular library users are afraid to come in. So they called in like the Breen Center and Health Department and even some churches and Senior Center and all these other places. And they said, can people come and help? Just because the library and the people in the library are amazing. They're such, they show a lot of compassion, but when some of these behaviors cross the line, like last month I was there and somebody was really falling down drunk and they wouldn't leave for the library people. And it's like, okay, I think I know this person. I'll go up and talk to him. So I said, okay, this is scary for other people to see you like this here. So let's go outside. And oh no, I'll be good. I won't bother anybody. I said, no, it's not a choice anymore. We need to go. And because I knew him, he went with me. But it's taking so much time away from I don't know, I'm venting now. I should stop complaining.
You're not complaining. You're describing a really hard circumstance, and it feels like you handled that one really well. It helps so much that he knew you and he trusted you. It is, you guys know this, it's really hard to take care of somebody who's under the influence of alcohol, right? They're not rational. They think one thing and they act a different way, and they can be really scary. And it's a place where a lot of times they end up in police custody and they sober up. I mean, it's one of the roles that jail serves is we put people in protective custody. They haven't committed a crime, but they're acting in a way that's not safe. And so they come and they sober up basically in the jail. And it's a weird thing that happens. I don't know if people know that that's what happens, but they get sober up enough. We all also can assess them medically to make sure they're safe. And then they go about their lives. So being under protective custody is pretty common. But Vicki, again, I really feel like whether it's the Breen Center, Clinical Support Options, ServiceNet, CHD, BHN, I don't know which one of the big entities, every one of those psychiatric facilities runs de-escalation trainings for their own staff. I feel like the librarians should get that. That would be a good community thing to be off to offer. And I just think we need to figure out who in Berkshire County or Franklin County is doing that work. But it's one of them. They all do them. Let's see, the Worcester thing was referring to the overall county. What about Worcester County? Recognizing that UMass Medical Center's large presence there. I don't know how to answer the whole Worcester County, but Worcester County, you know, it's a big, huge county, right? It, like Berkshire, runs all the way north and all the way south, and it has lots of very rural areas, and then it has Worcester, it has Leominster, it has Fitchburg and Athol, and it has a bunch of other towns in it as well. Worcester County, because it is so big, most of these substance opiate treatments are only really available in Worcester. There's one in Leominster and one in Fitchburg, but it is actually one of the counties that has the least available treatment. And I'm sad to say, my husband's a professor at UMass Medical. They're less aggressive about treating addiction. They're less sort of out in the public with it than, let's say, even Bay State has or Berkshire Medical has been, which is a little bit of a disappointing thing. And the jail in Worcester County is considered the worst jail in the state. The sheriff is the sheriff, and that person gets elected to that job. And their medical care and their treatment for addiction in that jail's abysmal. They were forced by the Department of Justice to provide treatment. They're not doing a great job. I would say that if the sheriff were on this call, I mean, the sheriff knows my opinion of the work they're doing. It's not very good. So you don't want to be the worst jail in the state, quite honestly. You want to be the best jail in the state if you could be. Do you think legalizing drugs would be one way to deal with the problem? Like prohibition, we'll never be able to stop the availability because it's so lucrative. Yeah. I mean, the argument for legalizing drugs would be a safer supply. And do I personally believe that legalizing drugs would be better than what's happening now? Maybe. I think that getting drugs into people's hands that are safer would just make everything better. And I've often thought, well, how do we really do that? So the cross-contamination of the substances, I think people ask themselves, why would you put fentanyl and cocaine? Like, why you doing that? You're going to kill your customer. And I actually don't think most drug dealers, one, I don't think they're really thinking about their customer base and customer satisfaction. And I think a lot of it's actually not intentional. I think people cut their drugs on their kitchen table or wherever. They have the same scales, the same bowls, the same devices. They don't have a clean technique, right? Like they're not running FDA approved labs. I honestly think that bringing in some high-tech people to sit down with them and say, look, you're accidentally cross-contaminating things. It's creating havoc and people are dying because of it. Let's get a better system here. I'm not saying they have to go drug dealer to drug dealer, but put it on YouTube or TikTok about how to cut your drugs more safely would literally save lives. Now, that seems like a bananas idea, but it isn't, right? That's going to be more likely to help people than us trying to legalize it. You know, we all spend our time in addiction medicine wishing for the old days of heroin. Heroin was a much safer drug. It was way less potent. And most interesting to me, it lasted longer. It had a better high, and you really only needed to use it once or twice a day. One of the many problems with fentanyl is it goes up and down all day. And so people are sometimes needing to use every single hour, which means every hour that you're using, you put yourself at risk for an overdose, you pierce your skin, so you put all of your organs in harm's way. The rates of having endocarditis or spinal abscess or skin soft tissue infection are so much higher than they used to be. And I think you all know, because you're well-knowledge people, xylazine, which is this veterinary tranquilizer coming out of, originally from Puerto Rico, but coming up the east, is cut into the drug supply very heavily locally. So 40 to 50% of the drug supply in Springfield and Holyoke, we test it every week, has xylazine in it. And so I'm taking care of people who have wounds that won't heal. They've lost their limbs, arms and legs. It is bad for them and it's expensive. I am a cheap Yankee. At the end of the day, the other thing that drives some of my work is I hate the expense of these drug-related diseases. Losing a limb, that costs a lot of money. That person's now disabled. They can't support their family. And just literally losing the limb in the hospital takes a lot of money. So the drug supply is getting more toxic and poisonous, and it will never improve. So yeah, having a safe supply would make me a lot happier.
There's also a question right above that one about referrals.
Oh, where to send people to based on what they have. Yeah. So I think you guys know this, but you know, if people need treatment for substances, it depends on the substance. So if it's an opiate related disorder, there's multiple throughout Franklin County and Berkshire County, people who take care of people with opiate use, either with buprenorphine or with methadone, right? There's 2 methadone clinics in Greenfield, and there's methadone clinics now everywhere. There's only 2 in Berkshire County, Pittsfield and North Adams. But in Pittsfield and North Adams, there are multiple people who use buprenorphine, both orally, that's also called Suboxone, or as an injectable form that you can get people in. In Franklin County, we have, everybody takes care of people. Like there's not a single clinic that doesn't provide buprenorphine. And I think you guys know this, you no longer need a special waiver to do it. If you have a DEA license, you could prescribe buprenorphine as of December 31st or 29th, 2022. So there's no excuse for somebody not to provide that life-saving drug to somebody with opiate use. If you have somebody who has an alcohol use disorder and they have withdrawal symptoms, they really have to be managed in an inpatient setting unless they have a skilled person taking care of them. Meaning that sometimes I will do an outpatient alcohol withdrawal protocol, but I really need to sit down with the patient and make sure that they're safe enough to do it, because alcohol withdrawal can kill you, right? And doing it by yourself and deteriorating at home without anybody checking on you, that's not going to be working for anybody. We don't want you to die. So if you're somebody who says, oh yeah, I've DT'd before, I've had a seizure before, boom, you're going to the hospital to get off alcohol. That's the only safe way to really do it. Or going to McGee, or another ATS or detox level of care would be another safe way to do it. But if you have somebody, so those are the obvious cases. If you have somebody here just not sure is struggling, like marijuana is common. People will bring their younger people to me to assess for marijuana use. Marijuana is an addictive substance. Are there people benefiting from it? Sure, there are. Are they addicted? Many of them are not, but many are. And it's especially the young people that cause me concern, because they're causing this sort of overuse of marijuana while their brain is still developing, and it can really derail your life and your trajectory of education and career and feeling good about what you're doing. So helping young people use less marijuana takes a little effort, because you need to help them with the withdrawal symptoms. You do withdraw from marijuana. It's mostly insomnia and anxiety and agitation. So you need to help them with that process. So Rebecca said that Berkshire Medical Center has monthly de-escalation training for all the employees. So we should have somebody called Berkshire Medical Center and get that team out to the library or into other places where escalation happens. That would be great. Oh yeah, look at that. Rebecca's partner does it. Good for Rebecca. So let's get in touch with Rebecca.
I'm sending the information to Christy and Corinne now.
Wonderful.
So,
Thank you.
Sue Keller, is there a web-based directory? BSAS, if you go online at BSAS, there's all kinds of things there about it, but also just Berkshire County has so many good resources that know all the resources, but I'm now, Corinne and Christy, I'm sort of at a loss for words. What's the equivalent of the opiate task force for Berkshire County?
I believe that's Berkshire Harm Reduction, unless I'm incorrect on that.
I missed the question.
Christy. So the question is, somebody's looking, where's there a web-based directory to find things, or who do you call to know where to send people? And Christy was thinking it was Berkshire Harm Reduction. It might be that.
Yeah, there's a it's gosh, I can see the acronym, but you know what, we'll find out and we'll send it out to everybody following.
Okay. And in Franklin County, the Opiate Task Force of Franklin County, North Quabbin, Tapestry, they have a full resource of everybody that you would be sending somebody to get treatment. The emergency rooms, I can't speak for the Berkshire emergency room, but based in Franklin, if you walk in there with an opiate use disorder or an overdose or a soft tissue infection and you're interested in treatment, they'll start you on buprenorphine or methadone right there, then and there, and then they hand you off to a clinic immediately that will see you the next day. That's true at Bay State as well, that we have an immediate handoff between the ER and any one of our clinics to start treatment immediately. And the hospitals are getting better and better about doing treatment. Nobody's perfect, but they're getting better, so much better than they used to be. So somebody asked the xylazine question, and then Margaret Wright wrote in the xylazine. There's a whole bunch of xylazine stuff. The New York Times has been covering it in the last 2 weeks. Joe Biden came out 3 weeks ago with a massive statement on how bad xylazine is. So if you Google around, you'll see it. And then brains are fully developed at 25 ? Yeah, it depends on the person. There's a variance, but some people are 23, some people are 26, but it's around that age. I would argue girls are a little faster than boys, even at that age. But yeah, and you know, again, for me, it's about postponing use until closer to brain development. Do I think a 22-year-old or 21-year-old should never ever drink? I think they just have to be aware of, Canada came out 3 weeks ago with a very strong statement, and I sent it out to all my colleagues because I was impressed by it. In the statement, they did a meta-analysis of all the studies on alcohol that said there was health benefit to drinking, cardiovascular health benefit. At the end of the day, most studies were funded by the liquor industries. They just were. They were funded by the liquor industry. And when they reevaluated them, there is no health benefit to alcohol. There's none. Over the age of 75, the amount to drink is 2 ounces or less. There might be a tiny bit benefit there over the age of 75, but most people at that age really shouldn't be drinking because they're going to fall and trip and break a hip. But there's no health benefit. And in Canada, they're making it clear. Really, there's no amount of alcohol that's safe to drink. It's really a neurotoxic drug. Just is. And most of us should be drinking a lot less. Some of us should not be drinking anymore. And even reading that has changed my relationship to alcohol. I've been shifting away from alcohol for many years now. It makes my sleep terrible. I don't know who else has that problem. Like even a glass of anything, I can't sleep at night. It's not worth the calories anymore. And it's a neurotoxic drug. So if you are having your glass or two of wine at night because you think you're doing yourself heart health benefit, nope, you're not. Don't fool yourself it's helping you. It is not. You can choose to drink. I'm not going to judge anybody for that, but don't convince yourself it's helping you. Robin wrote connect. Oh, connect. Yeah, connect is part of the opiate task force. So Robin, thank you for writing that. The connect program knows everything. Thank you. Ara wrote about considering studying impact of marijuana, EEG brain activity. You know, I haven't seen the EEG brain activity at all. They're doing MRIs and functional MRIs on adolescents using all substances. There's a 10-year brain study that NIDA has started. I think it started in 2016 or 2018. So we're about halfway through that study, and they are doing functional MRIs on a huge cohort of kids. That will be very interesting data when that comes out. But again, I think we're only halfway through that study. What other thoughts or questions do people have? I don't want people to feel hopeless. Don't feel hopeless. I take care of people get better all the time. I take care of people struggle. But there's so many people. There's people in your lives who used to struggle and now they're okay. You know that. And there's people in your lives who are still struggling.
All right. Any other questions?
Christy, would you let me answer this? Could you elaborate on the effects of drugs cut with xylazine? Clive, I didn't see that question before. So xylazine, this tranquilizer, is a drug that is an analog to a medication called clonidine. Clonidine we use for blood pressure. We use it for like central restlessness. It is like clonidine times 100. So it's a sedative that knocks you out. People will describe that they were knocked out for hours on end. And it's not an opiate. So Narcan does not work. It's not, they're not related to each other. Narcan cannot revive you from a xylazine overdose. So one of the problems with this is that people land in positions that are not good for their health. They might land in a way that they land on top of an arm or a leg, causing a lack of oxygen going to the tissue, which can cause necrosis or compartment syndrome. And when you have a compartment syndrome, for those of you who work in a hospital, you know what that looks like. You literally have to flay the body open to release the pressure, right? These people have enormous wounds or they lose the limb. It's extremely expensive to take care of. It's a really hard wound to close. It is very complicated. So part of this, there's lovely harm reduction right now on how to help people in a xylazine overdose. Like one, you've got to position their bodies in a way that they're not going to crush and damage tissue. It's really important. The treatment is CPR. In fact, the treatment is oxygen. If you have somebody who's overdosing on xylazine, they just need oxygen. Now, the problem is I carry Narcan. I don't carry oxygen. But it's one of those situations that if we just get oxygen on people, they're going to be okay because they won't cause themselves any brain damage. The xylazine test strips just got approved out of Canada a month ago. They're kind of expensive. They're the same price as fentanyl test strips, but the state provides us the fentanyl test strips for free. And Tapestry isn't using the xylazine ones yet because they're pricey, and the state's not providing them for free yet. That's something that will happen. But I think just talking to people, helping people get into treatment, and then talking about if you're going to use, you should presume that xylazine is in the system. And when you use, you always use with somebody else. One of you goes first and the other one would follow. If that person who used first looks like they're nodding out, you would really want to put them into a comfortable position so they don't do tissue damage. I know I'm talking to a bunch of people who don't use, but you should know how to do harm reduction talks with people. Harm reduction is not just about Narcan. Right? People will use, and let's keep them healthy while they're using. I'm not asking for the world. They need clean needles, they need alcohol, they need better techniques. Like all of this thing matters. It's why a safe consumption site is actually a good idea, because it brings people into a space that is medicalized and is safe. If somebody overdoses, you can protect their airway, you can get them Narcan, and lots of times they're going to be ready for treatment. It's an opportunity to get people into treatment. There's not any safe consumption site in Massachusetts.
Looks like a question about PTSD, asking you to speak about PTSD and substance abuse.
Oh, yeah, I mean, Rick, that's the thing. It's the cause of many people's substance-related diseases, trauma history. And quite honestly, people with substance use develop PTSD, or it gets worse because they're treated so badly in the medical system. People don't ever want to go to the hospital when they have an opiate use disorder because they feel like they get treated so badly, particularly when they're hospitalized. Many places don't get people stable on treatment while they're hospitalized. And so they're incredibly sick and they're withdrawing and they're vomiting and they're having diarrhea, and they just leave. They discharge from the hospital, even though their treatment isn't done. Well, whose fault is that? That's on the medical staff. So again, I don't know about Berkshire Medical Center, but you know, I live on the I-91 hospital corridor, and Bay State hospitals use methadone and buprenorphine on the floor to stabilize people with a warm handoff to a provider in the community, which is, it's really basic medical care. It has to be provided to people. I don't know if there was something else about PTSD. Somebody said, can we talk about Narcan? Should we all have it on hand and know how to use it? 100%. Absolutely, Eve. You and I know each other, but I mean, all of us, I don't know. I mean, you guys walk by somebody who's slumped over on the street. My hope is you check on them. I mean, I stare at them for a minute and make sure they're breathing. Sometimes if I think they're in a really uncomfortable position, I might lean over and say, are you comfortable? Can I adjust you? If they're not breathing, I have Narcan on me at all times. I've used Narcan. I have it in my car. I have it in my purse. I teach everybody how to use it. The number one people who saves people's lives with Narcan are people who use drugs. Yeah, EMS and the police are amazing, but by the time they show up, somebody's already used Narcan on the ground. So people who use drugs administer Narcan, and I pat them on the back every day. I'm like, goodness, you saved so many lives because you knew how to use Narcan. Narcan is available by prescription, but it's also now available over the counter. It's a little pricey, but it's so easy to use, Eve. It's like, I don't have it in my space right now, but it's a little squirt bottle or a little delivery device that you make one squirt into one nostril. Now, the problem with fentanyl is, you know, you have to wait a few minutes after the first delivery, but fentanyl overdoses often require more than one delivery. The first thing you always do is call 911. You need to activate the emergency system immediately.
But Dr. Potee, you're an expert at this. You see it all the time. I'm not, and so I'm not convinced I would recognize if somebody is actually overdosing or.
Right. But Eve, wouldn't you recognize if somebody wasn't breathing? Somebody wasn't breathing. Would you recognize that?
Yes, and so I can assume that that's an overdose.
No, you can you can use Narcan even if you're wrong. Narcan, I could give Narcan to every one of you right now. We could all practice squirting it up our nose, and unless you used opiates, you'd be fine, right? If you used opiates, you'd yank the opiates out of your brain and you would feel badly. But for all of us that don't take opiates, we can all be squirting Narcan all the time. It causes no harm. It does nothing. So 911 always first. Basic CPR evaluation of the patient. Are they responsive and are they breathing? If somebody's breathing, they actually don't need Narcan. I get that one all the time. They're like, I gave them Narcan. I was like, were they breathing? And they're like, yeah, they're breathing fine. I'm like, that's not an overdose. They may not have been responsive to you, but Narcan's not the next step, right? But you guys know, you check their breathing, you check their pulse, right? Or are they oxygenating their brain and getting blood to their brain? That's what you want to know. That's CPR. Everybody should, I mean, this is basic stuff. You guys know, everybody should know CPR. Everybody should know tie the tourniquet. People, this is basic medical care that we should be able to provide people that we stumble upon. You don't need a medical degree to do any of that. And I know you, Eve, you can do anything. Okay, Karen said, can we reach more kids about vaping dangers? My goodness, yeah. So yeah, do you know, Karen, that our kids, the smartest generation on the planet, where they were going to eradicate nicotine addiction because they were not smoking, they hate cigarettes, they're disgusted by them. And the rates of tobacco use with a cigarette in a cancer box was going to almost nothing. But vaping, as everybody knows, because it's cool, it's sexy, it tastes like, you know, creme brulee or whatever, is way up. And those vape pens are incredibly addictive because it goes, the way the delivery system is, these nicotine salts goes right to the brain. They're like nicotine times 1.5 or 2 in a tobacco in a normal cigarette. So they're super addictive. And that again, that is like 9-year-old, 10-year-old health class conversation. And it needs to happen all the time. And those things should not be available anywhere. They should be banned as far as I'm concerned. I think that vaping devices can be helpful for people to stop smoking as adults when they get there. But otherwise, and they should be a little harder to come by. And they need to be inspected by the Food and Drug Administration, right? A lot of vape pens have God knows what in them because they're not inspected. There's only one brand that's been inspected by the FDA. It just got inspected recently. It's called Vuse, V-U-S-E. Otherwise, I don't recommend any of them because I don't know what's in it. Nobody knows what's in it. Corinne said we have CPR and Narcan trainings upcoming, so I love that. And you guys know a movie, The Anonymous People that Robin mentioned. If you guys go to Google, or not Google, if you go to YouTube and just type in how to use Narcan, there's a lot of good videos that are really very accurate. And Tapestry runs trainings online all the time and will give you free Narcan.
Same with Berkshire Harm Reduction in Berkshire County. Both of
Excellent,
those
Christy.
will
Thank
provide
you.
them free.
Excellent. Okay, team. Well, it's almost, I think it's 8 o'clock your time, 7 o'clock. I'm in Texas right now. So you guys have been great.
Dr. Potee, thank you so much.
Thank you. Thanks for
Really
inviting me. Thanks for having me.
Yeah,
Spending
that
your
was-
night with me.
That was some amazing information, some things I know I hadn't thought about. I'm sure some other people felt the same way. So thank you so much for joining us.
Thank you. Bye, everyone.
Have a good vacation.
Take care.
Everyone, thanks for coming.
Thank you so much.